بسم الله الرحمن الرحيم. I'm Dr. Fahad Sab'an. I'm chairing this imminent meeting, the first part of the session tonight. And just I'd like to thank the organizing committee for giving us the chance to share with my colleagues tonight and the rest of the this imminent meeting. Tonight we have, in fact, colleagues and friends whom I know and everybody knows. They will shed light on some of the topics tonight. So I will start with my colleagues and friend, Dr. Mohammed Al-Dawish, who's a consultant and a director of endocrinology and diabetes department in Prince Sultan Military City. He's known to all of us. He finished his fellowship in endocrinology and diabetes 2009. He further did his training in thyroidology in the University of Alberta, Edmonton, Canada, 2011. And he will give us tonight a shed light on the thyroid nodules assessment and management. Mohammed, go ahead.
Thank you, Dr. Fahad, for presenting me in this nice, huge meeting. Also, I'd like to thank the organizing committee for having me, Dr. Sheikh, Dr. Saud Al-Sifri, all colleagues. I have been assigned to present a thyroid nodule assessment and management. Bismillah ar-Rahman ar-Rahim, wa ma utitum min al-ilmi illa qalila. I don't have any disclosure. Question should be addressed, or my outline objective, how common thyroid nodule, what about risk assessment of malignant or non-malignant, rate of malignancy as a percentage per se, which guideline to guide us in management and assessment of this thyroid nodule. Also, I will talk about biochemical, radiological, statistical, as well as molecular issue on this thyroid nodule. I will start by a case who is a 36-year-old lady present with a large thyroid gland, a goiter. What do you think who should be involved in managing this patient? You can see it's a huge of subspecialty can be involved, starting from family physician, internist, or endocrinologist, who usually starting by investigating this patient, approaching them in the clinic. Definitely our radiology plus minus nuclear specialist. We require to have a FNA or a surgery, definitely pathology with endocrine surgeon, oncology, specifically if we are dealing with like medullary and anaplastic subtype of thyroid cancer, as well as our colleague from medical physics specialist. So we can see how is it a huge burden to the hospital just only as a thyroid nodule involving more than 9 departments. How common thyroid nodule we are seeing? Is it 5%, 50, 70, or all of the above? In fact, the answer is all of the above. Based that on palpation, you can pick up 5%, but doing autopsy up to 50%. When you are doing a neck ultrasound or sonography, even last studies showed up to 70% you can pick up. So subclinical nodule is an emerging and hiding demand for our attention. Starting by risk assessment, we start by the age. Usually a thyroid nodule can be picked up or seen in age group from 20, even up to 50 to 60. But I'm mentioning here the age. When it started less than 14 or above 70, this ring the bell. Maybe you are dealing with a malignant thyroid nodule, family history of thyroid disease, very important, especially in medullary type. Even nowadays, we are seeing BTC, I mean papillary thyroid cancer, familial type as well, previous head and neck radiation, whether a treatment or diagnostic, if it's a huge amount of radiation, yes, one of the risk factor to develop thyroid cancer among thyroid nodule population. Rate of mass growth can pick up which malignant we are dealing, anterior neck pain, I mean thyroiditis, or sometimes a cystic nodule, get a hemorrhage and get a large dysphonia, dysphagia, or dyspnea. As you know, thyroid gland surrounding structures are trachea, esophagus, and vocal cord. Whatever have been compressed can lead to these symptoms of hyper or hypothyroidism. Very important, because this one can guide us even from beginning. To be honest, this is the most important slide in my talk. If you didn't figure out from beginning, you can be lost up with your patient. What's the initial test? Always you have to request TSH. The main reason for that, there is strong recommendation. If the TSH is normal or elevated, you don't need to do a thyroid scan, which we are seeing now as a pitfall from our colleague. They're requesting thyroid scan for every patient. It's indicated only if there is suppressed TSH. Otherwise, you should proceed to thyroid ultrasound only rather than scanning. What about thyroglobulin level and calcitonin as risk assessment? There is strong recommendation that serum thyroglobulin is not indicated, even calcitonin is not indicated, except in a case of medullary cases in the family. Yes, may be justified to order calcitonin, and keep in mind medullary cancer usually less than 1 or 3% among the whole thyroid cancer. What about imaging, MRI, CT? Again, there is no clear recommendation to do it as a routine, but in case of like compressive symptoms, patient going for surgery, the surgery they want to do more specific mapping, yes, justified, or looking for lymph node in the cervical region was not visualized by the CT, by the ultrasound initially. What about PET scan? Again, there is strong recommendation that to do FNA only in one case if there is a focal PET scan, and this is not routinely requested. This FDG or PET scan, if you have like incidental finding and you find a focal, the reason to do fine needle aspiration, proven by many study, up to 30%, this nodule can harbor a malignant feature, then you have to proceed for FNA. But if you find diffuse FTGs supportive of thyroiditis, there is no indication to do fine needle aspiration. A common practical, you are seeing multinodular thyroid goiter. The question, which one I should biopsy? You should take each nodule as a separate evaluation. I mean, if you like find 2 or 3 nodule requiring FNA, yes, we can do FNA 2 to 3 nodule per session as well. The question now comes, want to perform thyroid ultrasound, because we have seen up to 70% of the population, if you are doing ultrasound, you can pick sub-centimeter thyroid nodule. So the main indication is risk of thyroid malignancy, or if you palpable thyroid nodule or a goiter, or if you dealing with neck lymphadenopathy suggestive of malignant lesion. Keep in mind, there is strong recommendation. Again, our radiographer or radiologist, they have to look for lymph node, cervical lymph node, because if there is any suspicious of cervical lymph node, maybe you need to biopsy it regardless of the thyroid nodule itself. We come to the common question, which guideline I should use in my practice. I just choosing a few guidelines. They are the most famous dealing with a thyroid nodule or thyroid disease in general. ACE or ACE or AME with a nice recommendation. One of the famous guideline, American Thyroid Association guideline. This is have been done on 2015, published in 2016. I hope this year we'll have a new guideline. It's one of the popular guidelines used with a nice evidence ranking. There was a recent guideline just published 2 to 3 months ago by American Association of Endocrine Surgeon guideline. I have read it in a quick way. It looks more promising, more clear with evidence ranking as well. I suggest all my colleagues to have a look to this recent guideline. Lastly, in 2017, a colleague, a radiologist, also an endocrinologist and endocrine surgeon, they have done what you call it thyroid reporting and data for thyroid ultrasound. This one, if you're aware about BIRAD for the breast, which is more promising, and this also one, the staging, much promising, and that's why always you need to sit with your colleague at your institution, I mean the radiology, you have to figure out which one we need to be reported, because you don't need to be lost up. In Prince Sultan Medical City, you have agreement that all thyroid ultrasound, they should depend on this imaging. I mean, the conclusion, the report. Before, in 2009, we are saying FNA, procedure of choice for thyroid nodule, but lastly, it should be clinical indicated based on the patient, based on the ultrasound finding. Also, nowadays, we are depending more on ultrasound finding, because this can figure out risk of patient even for the follow-up. So mainly ultrasound can guide you which nodule should be biopsy. Even risk stratification can give you clue by an ultrasound, whether pre or post-operatively. Last question, what I have in my whole slide, what risk of malignant thyroid nodule? Is it 3%, 5 to 10, 20, 90? Again, the answer is all of the above, based on ATA, American Thyroid Association guideline. If you have figures of the ultrasound, high suspicion 90, intermediate 20, low about 10%. And this is the one how they are figuring out based on the calcification, hypocogenicity, these by ATA. And you have one by the TIRAD, what I mentioned to you a while ago. So please figure out with your colleague in the radiology department to be fixed themselves which reporting by ultrasound, because difficult sometimes to read for ourselves. Even we advise our colleague to read your own ultrasound, but the report should be clear from radiological department, because this is an illegal issue. Our decision as a physician, I mean endocrine or family physician or internist, we are depending mainly on the report of our colleague from radiology. It should be clear the end of the report, I mean the conclusion of the report. This is the ultrasound of the cervical lymph node, the highly specific finding, cystic changes, or if you find calcification, and lower specificity, who's having peripheral vascularity. And you can see this is a most common we are seeing in the report, loss of fatty hilum. Yes, it's a sensitive 100%, but you can see only about 29 specificity. I mean, about 30% only specific. This one I was talking a while ago about it. This is what we call the TIRAD. There is 5 TIRAD, 1, 2, 3, 4, and 5. This is based on the point. And there is also nice recommendation when to do FNA and even how to follow it up. And this is the risk of malignant among all these 5 TIRAD. If you decide with your patient to proceed for fine needle aspiration, so there will be a fine cytology. You can see this is a Bethesda system of reporting. Bethesda, the name, it's a city in Maryland in USA in 2007. Most of the famous pathologists and cytopathologists, they sit together and said, let's help our colleague, a physician, to decide where to go after the cytology rather than a full description. And they end up by 6 category. We call it Bethesda 1, 2, 3, 4, 5, and 6. And each one of these Bethesda have its own risk of malignancy before sending them to the surgery. So when you are sitting with your patient and you find the cytology, you have to discuss with him what's the risk of malignant. I should proceed sending you to endocrine surgeon for whether lobectomy or total thyroidectomy. The next slide will be more explanation. I'll start by Bethesda number 2, which is the benign, and it can harbor more than 60 or 70% of the total thyroid nodule biopsy done. In my institution, we reach about 72% become benign. What's the recommendation? Usually should repeat it 1 to 2 years. If there is high risk, maybe 6 months to 1 year to repeat ultrasound. If there is intermediate risk, even up to 2 years. So you need to be much benefit with your patient after this result. If you did after 1 or 2 years, and if you find less than 20% of the size increasing or less than 50% of the volume, you need to do a fine needle aspiration again. You can just make it 2 to 3 years later on to do an ultrasound. Simply, the thyroid cancer, alhamdulillah, it's enduring disease. The mortality lasts 50 years, less than 3% as a mortality per se. Let's go for the Bethesda number 5 and 6. This is easily decision between you and your patient. You should go for surgery. Whether if he is Bethesda 5, could be lobectomy versus total, but if it's Bethesda 6, you should go for total thyroidectomy. So we now have clear cut among benign and 5 and 6. If you go to non-diagnostic, which is what we call it Bethesda 1, this is little dilemma, but the recommendation nowadays, you should repeat the biopsy 3 to 6 months. If become again Bethesda 1, you should go for surgery. The most striking or dilemma nowadays, we have these two entities, Bethesda 3 and Bethesda 4. It is, we call it indeterminate. You can see the risk 10 to 30, in the Bethesda 4 up to 40%. Recommendation for Bethesda 3, you should repeat it 3 to 6 months again. If the FNA become again Bethesda 3, it's advisable to go for lobectomy or total thyroidectomy, or to do molecular marker. We'll talk about molecular marker later on in a coming slide. Bethesda 4, up to 40% can have malignant. So most people, especially the European guideline, they are toward sending them the patient for lobectomy. Even in my institution, we are sending most of the patient for lobectomy who's having Bethesda 4, since we don't have a molecular marker in our institution. This I would like to share with you with the Bethesda 3. It was what we call the FLUS as well. These many studies have been done. You can see the risk of malignant ranging from 37, some institution 22, 34, and even one of the institution, which really, to be honest, they get high number of Bethesda 3. It was 55. And here, a study done with my colleague in Prince Sultan Medical City, we have a 463 Bethesda 3, and our rate was 27% having malignant. Last few slides about molecular marker. We have a test. This molecular marker usually are taken from the FNA. Unfortunately, we don't have here in the kingdom to do it. Usually sent to outside to USA. Would like to tell you from beginning, this is little costly. Each test, it will cost about $4,000. I mean about 12,000 riyal by doing it. So keep in mind the cost. Is it cost effective? We can discuss it later on. First test, do we need to rule out or exclude malignant, which is the most sensitive test we have it. This is what you call it a pherma gene expression. Now this is can pick up more thousand of gene abnormality, we call it. This is most striking test we have it, the most sensitive one. If you want to roll out, there is another test, what you call it, mutation analysis. Maybe 10 years ago, they are testing only 7 gene panel, we call it. Then become 12, then become 28. Now we are lucky to have more than 112 thyroid-related gene can be picked up by this test. So the test is highly specific. I mean, to roll in the test and identify the malignant. What's available now in the commercial? Again, more people concentrated on Bethesda 3 and 4 because this is indeterminate. You cannot figure out surgery and non-surgery. We have 3 commercial available. We have a Pherma gene sequencing classifier, which can have about 91, but unfortunately 68 specific. If you are doing mutation analysis, that's what I mentioned a while ago, 112 gene. It's highly sensitive, highly specific compared to the previous one. And the last test have been available last few years. They combine together microRNA gene plus mutation analysis, and you can see it's highly specific, 85 and range from 75 to 92%. Which test to do? It's up to which one lab they are using. If you are lucky enough and we don't care about the cost, which shouldn't be the real practice, to do both of them, the upper 2, then you will have only of the highly sensitive plus the highly specific result. This is the last slide I have. Molecular marker is a good one to pick up a patient who should go for surgery, but also can give us idea about risk of a recurrent. For example, if you have, BRAF K600 or BRAF V600, it goes with more high risk of recurrent. The bad one, if you have combined BRAF with the TERT, that means risk of recurrent, even after total thyroidectomy, even after radioactive iodine, they are still high risk of a recurrent of the disease. So mainly can be used as diagnosis as also as prognostic factors. I would like to conclude, thyroid nodule is a common among population. General risk of malignancy less than 10%, even less than 5%. FNA is still the standard component thyroid nodule, but you have to make sure which established guideline to stick with it with your colleague from radiology, from cytopathology, even from endocrine surgeon. You have to figure out which guideline you prefer to go for it. Bethesda system, I think this is not should be, it's have to be. We notice, unfortunately, many hospitals in our kingdom, they are not doing the Bethesda system. They just doing full description. I think advised go to the Bethesda system because you have a solid evidence what to do after the result of thyroid cytology. Lastly, accuracy of molecular marker, rely on the institution and malignant rate. That's why always you have to figure if you have done your total thyroidectomy among Bethesda 3 or among Bethesda 4 in your institution, you have to figure out what's your risk of malignancy because it varies from institution as well. And thank you for your kind attention.
Thank you, Mohammed, for this nice, focused explanation of thyroid nodules. And for no further delay, I'll present the second speaker, Dr. Hussein Raif, who is a consultant endocrinologist, King Faisal Specialist Hospital. He's also a member of Saudi Neuroendocrine Tumor Group. He will talk about neuroendocrine tumor diagnosis and management. Dr. Hussein, could you go on?
Assalamu alaikum and good evening, everybody. Really give me a pleasure to be with this very large seminar, and I would like to thank the organizing committee, the society, and the chairman, Dr. Saud Sufri, and Chairman Dr. Saban, for this opportunity. So we heard a very nice presentation from Dr. Dwaish about the issue of thyroid nodules and workup. Here is another Here is another endocrine neoplasia issue, which is neuroendocrine tumor. It is much more heterogeneous than thyroid. It is less evidence-based. It is rare, more rare than, of course, thyroid nodules, and a little bit more complex in terms of the diagnosis and management. So neuroendocrine tumors are kind of interesting but quite heterogeneous type of tumors that arise from neuroendocrine cell. A neuroendocrine cell can present across the GI tract, across the pulmonary tract, and many other sides of the body. It has been increasing, although we think it's rather rare, but has been increasing in incidence, partially because we're discovering more, but maybe for other reasons as well. It has increased almost 5-fold in the last 30 years. Now, there are challenges in the diagnosis and the management that we will talk about in the next 15-20 minutes, because this is a tumor that is usually discovered late, as most of us know. And the symptoms that can be quite nonspecific, though. On average, the subject or the patient who has neuroendocrine tumor can go for a number of years, a median of 9 years, before the diagnosis is made. And this delay in diagnosis certainly has its impact on the survival of the patient and also on the morbidity of the disease, local and systemic morbidity. Therefore, we think awareness and early diagnosis may be very important, although it's not easy, as we will see. We have actually developed good diagnostic techniques and methods in the last 2 decades or so, but continue to be quite challenging. So this is just to show you the increase in the incidence of neuroendocrine tumor, and this is a worldwide, although these data now from the SEERS data from the US, but it's actually a worldwide increase. And you see the increases, all kind of neuroendocrine tumor, they're all increasing, but specifically intestine and more specifically rectal in some areas in the world. Rectal neuroendocrine tumor has increased to be almost the most common type of neuroendocrine tumor diagnosed recently. As I mentioned, late presentation is common. So liver metastasis can be seen in presentation at different levels. So if we have a small intestine neuroendocrine tumor, this could be as much as half of the patient presenting with liver metastasis. So the number can be quite small in appendix and rectum and stomach, and as you will see, this is a good opportunity here to diagnose those tumors early before they present with distant metastases. And as also this shows that survival does directly relate to the extent of the disease. Not only the presence of metastasis, but regional spread all affect the prognosis and even the burden of the metastasis. So here in this study, they looked whether liver metastases were less than 5 lesions, more than 5 lesions, or even beyond the liver to become extra-abdominal metastasis in the bone or the lung or the peritoneal area, where, as you see, the survival can decrease quite a bit as the burden of the disease continues to increase. And again, this is another reason why those tumors should be identified as early as possible and managed. So clearly, lower grades and stages of the disease have better curable rate and favorable prognosis. Again, this is a very important reason to diagnose those tumors early. And local and systemic morbidities can occur due to either the tumor itself or to the secretion of those tumors. because those tumors some of them have the ability to secrete local hormones, causing local reaction, like in the peritoneum, like fibrosis, or distant hormones to cause hormonal secretions, like in insulinoma or gastrinoma or ectopic Cushing syndrome, or even heart disease in carcinoid heart disease. So again, the advantage of early recognition of those tumors is to prevent those morbidity and mortality from the tumor, either due to its site or due to its secretion. Those tumors are indolent. We have patients who carry those tumors with the liver metastasis for 10 years, 15 years, 20 years. But we have to keep in mind that those tumors kill the patient eventually. So we should not really kind of relax, and we should continue to have options for the patient that will improve quality of life and maybe survival. There are challenges to the early recognition of those tumors. Why is it difficult to diagnose neuroendocrine tumors early? And these are one or some of the reasons. First, they are rare, so we don't think of them that easily. Their symptoms and presentation can be quite nonspecific, as we will see. They present late, often with metastasis. Therefore, they may be challenging in the management. And our diagnostic tools, whether it's biochemical testing or radiology, has limitation. So we have also caveat and limitations in the diagnostic tools. This is a survey that's done through patients, and I thought it would really give you a reasonable idea about the disease from the patient's point of view. It was done in many centers in the world, asking patients who have neuroendocrine tumors about their presentation, their symptoms, etc. So the first thing we learn from this, that the time to diagnose, times between first symptom that the patient experienced and the diagnosis is quite long, even in centers in developed countries. And on average, that period was 52 months. So almost 4 to 5 years before diagnosis from the first time of their presentation or first symptom they experienced. Another thing we learned that we mentioned before, that tumor metastasis at diagnosis is quite common. Actually, almost 60% of the patient will have some sort of metastasis to other organs at the time of the diagnosis, and it will be only confined to one organ or one site in about 38% of patients. This is interesting. This is the number of healthcare providers needed to, a number of visits needed to diagnose, to make the diagnosis of neuroendocrine tumor in those patients. And as you see, these are the percentage of the patient in green columns, and down is the number of healthcare providers. So as example, in 15% of those patients, there were 3 care providers before the diagnosis was made. In 12%, 4 healthcare providers or physicians. In another 14%, about 6 to 9 different physicians or even more before the diagnosis was made. How many visits? Again here, and this is the percentage of patients, and you see like on average, there were 5 to 6 to 7 and sometimes even more visits to the physician or to the hospital before the diagnosis was made. So again, this reflects the difficulty in the diagnosis. The patients here were asked whether their diagnosis was made after the first investigation, or was there any other diagnosis was made. So about quarter of the patients, after their initial symptoms and presentation and testing, they were diagnosed with other condition other than it before a correct diagnosis was made. So a quarter of the patient will have a wrong diagnosis. Another quarter of the patient were diagnosed as a neuroendocrine tumor after the investigation. But here, another quarter who were diagnosed with this diagnosis, again, for different conditions. So they were diagnosed with different conditions before having the diagnosis of neuroendocrine tumors. And what are these conditions? It's listed here: irritable bowel syndrome, gastritis, anxiety, inflammatory bowel disease like Crohn, asthma, menopause, and these are the percentage. So a lot of patients were diagnosed with some sort of a GI disease that actually was a wrong diagnosis or was earlier diagnosis before the correct diagnosis of neuroendocrine tumor was made. These are the symptoms actually that reported by patients: general fatigue, muscle fatigue, weakness, almost 60% of the patient, very non-specific symptoms. Now, GI symptoms like diarrhea, abdominal pain, or cramping were quite common and should be always a clue for neuroendocrine tumor. Skin manifestation like rash, flushing are not very common, but should always alert us and are present in about 37% of patients, sweating in about 30% of patients, anxiety and palpitation in 26% of patients, asthma and wheezing in about a quarter of the patient, and then some other type of symptoms, including weight loss and even mental changes like confusion. So always, as we say, challenges comes also with opportunity. What are the opportunities that we have to make a good early diagnosis of neuroendocrine tumor? I listed here 5 different opportunities that we should take care of, or we should try to use to make early diagnosis of our patients. The first is endoscopy. We do a lot of endoscopy, and as we will see, discovering of neuroendocrine tumor with endoscopy, whether in the stomach or in the rectum or colon, would be an opportunity to diagnose those tumors early. Another opportunity would be when those tumors present with hormonal syndromes like glucagonoma, insulinoma, etc. So they have a clue. We have a clue that those patients might have a tumor that is neuroendocrine secreting. If we have a family with neuroendocrine tumors or suspected there is a familial disease, this is also another opportunity to look in the family members and try to diagnose early. So we also should take advantage of some advancement in diagnostic tools, including endoscopy, but also other tools that I will mention, including CT, MRI, and endoscopic ultrasound. And above and most of all, we have to have a low threshold for suspecting those tumors when we have a constellation of symptoms. I'm not going to ask you to diagnose it in anybody who comes with diarrhea or with a little bit of abdominal pain or cramps. But when we have a constellation of these symptoms, diarrhea and cramps, somebody who has some flushing, presenting with high blood sugar, symptoms that might suggest Cushing as example, or low blood sugar, we should always have this low threshold to think of neuroendocrine tumor. This is really a good opportunity, as I mentioned. So upper stomach neuroendocrine tumor and rectum neuroendocrine tumor, as you see here in the red line, have very high percentage of localized tumor, comparing, let's say, to small intestine or colon, which has much less localized and much more regional and distant metastases. So taking advantage of this by diagnosing those tumors early, and this is why they have this very high percentage of localized tumor, because they can be diagnosed early for endoscopy. Unfortunately, the classical carcinoid syndrome, that is flushing and skin changes, are not very common. They're probably just a quarter of the patients, but when they happen, they should always alert us. Flushing is usually not with the sweating, so it's different from menopausal flushing, and it is with purplish discoloration of the skin, like in this patient. And again, we should always keep eye on symptoms that suggest insulinoma with low blood sugar, gastrinoma with recurrent peptic ulcer disease and reflux and ulceration, glucagonoma with constellation of high blood sugar or diabetes with venous thrombosis, to alert us to these rare but very important syndromes. Finally, when we have suspicion for neuroendocrine tumor as a hereditary disease, like in MEN1 or MEN2 or familial paraganglioma, those usually are having multiple tumors, usually have rare type of tumors, and they present early in life. It always has to alert us to the hereditary forms, and therefore we should screen families with suspected disease. Now, in terms of diagnosis, of course, we depend still on biochemical markers like chromogranin. Chromogranin is a very sensitive marker for neuroendocrine tumor, but not the small one. It is usually sensitive to the tumor that has already spread. However, it's not specific. It has its own pitfall. So it is a good test to do, but you have to be careful that the patient should be off PPI for at least 3 to 4 weeks. Because PPI, as well as atrophic gastritis, can give you very false, high false chromogranin level. Other hormones like insulin, gastrin, glucagon should be only ordered when you suspect the specific type of hormone. Now, urinary 5-HIA, 5-hydroxyindole acetic acid, is a very good specific marker, but only positive when you have a carcinoid syndrome, usually with liver metastasis. Therefore, it's only going to be useful in about quarter or third of the patient, and it's usually a urine collection. And as I said, it's quite specific. In terms of tools, other tools, we have, of course, CT and MRI. They are usually the basic tools to diagnose abdominal or pulmonary neuroendocrine tumor. And recently, endoscopic ultrasound has become very, very useful to diagnose pancreatic and GI neuroendocrine tumor. There's a role for octreotide scan, which was recently replaced with the PET Gallium scan.
2 minutes.
Okay. So I'm going to quickly go through the CT findings here and just emphasize that it should be a triphasic because you might miss. PET gallium is a test that has been developed and much better than FDG PET to diagnose neuroendocrine tumor. I have only 2 slides for the management, or 3 slides, if you allow me, please. Surgery is still very important and the most important. Whether the patient has primary tumor with metastasis or without, because debulking of metastasis is extremely important issue in neuroendocrine tumor, and this can be done surgically or through embolization of liver metastasis and other metastases. Medical therapy, the cornerstone is biological treatment with somatostatin analog like octreotide or lanreotide, but also recently mTOR inhibitors like everolimus and TKI inhibitors like sunitinib has also been approved for treatment, especially of G2 tumors. Local therapy, of course, always important, including the recent use of lutetium and yttrium, but especially lutetium in systemic target therapy. So if I can go through this algorithm, metastatic tumor can still be considered for surgical debulking, including removal of primary tumor, especially if we can debulk at least 2/3 of the tumors of the metastasis, then it's worth doing because it has shown to improve survival and decrease, of course, the secretion of the tumor if it's a secreting tumor. Now, other therapy, including the biological therapy or certain type of target therapy or chemotherapy, can be considered in the G2. And the G3 tumors, these are usually poorly differentiated, and they are really an oncology concept. that's treated with chemotherapy. I'm going to skip a little bit through some of my slides because this is just more explanation of those different treatments. I want to alert you to the study of Netter. This is studied the treatment with lutetium and compared two groups. And the first time we have an evidence base that this target therapy with radioactive label therapy, lutetium can improve actually progression survival by almost 80%. But not only this, it showed for the first time improvement in overall survival. At King Faisal Hospital, we've used this now for the last couple of years with result that we're analyzing at this point. This is the survey. It just showed you exactly that patients receive different type of therapy. So this type of tumor always required different model of therapy from surgery to chemo to PRRT to radioembolization, and it's ongoing. So it's likely that your patient will receive all these therapies. This is my final slide, or the one before, just to show you that whatever you do is going to affect actually the survival of the patient. And if you go to more extensive surgery, survival is much better. And as you go down, of course, you do no treatment whatsoever, the survival is usually very poor, and in between all these type of therapies that we mentioned. Finally, NET is a very complex disease that will depend on so many different subspecialties. So a tumor board and a multidisciplinary team is extremely important, and it should be done mostly in tertiary care centers. Thank you so much for your attention.
Thank you, Hussein. And since you have a commitment and you have to leave, just I'm going to allow a couple of questions if you can nicely answer in short before you go from audience. The first question is, when do we suspect neuroendocrine tumor? And should we suspect it in which patient? And does acromegaly part of a neuroendocrine tumor?
So, of course, neuroendocrine tumor, neuroendocrine is kind of wide range. What I was talking about is neuroendocrine neoplasia, not including pituitary. So yes, you can consider acromegaly part of it or not, but it's not was not in my part really to discuss pituitary disease. What we meant is really neuroendocrine neoplasia that arise from neuroendocrine cells like carcinoid, like gastrinoma, etc. As I said, I'm always between, pushing people to be extremely suspicious and doing so much test that is not needed, and between a little bit too relaxed and not noticing patient for years. So I'm not going to tell you to go and screen with chromogranin everybody with irritable bowel syndrome. But as I said, when you have something that doesn't make sense, when you have a patient that comes to you again and again with the same symptoms, not improving with a general type of treatment, you have to suspect it. When you have a patient who have constellation of symptoms, so he has this abdominal pain on and off, he has this diarrhea on and off, he start to lose weight, etc., I will then have my threshold low enough to suspect and screen those patients, whether I do chromogranin or 5-HIA if I have the carcinoid syndrome component, or even CT scan of the abdomen with a triphasic contrast, which probably will discover metastasis. It may not discover the primary tumor sometimes because they're so small, and even doing an octreotide scan or PET gallium if really you have a lot of suspicion. So I think you're going to have to go gradually, give yourself enough time. I'm not suspecting you to discover those tumors from day one.
Okay, thank you. The second question already you answered in your first question answer. Just let me thank you very much for sharing with us tonight, and good luck. I know you have to rush, and let's shift the gear from the tumors and go to cholesterol and diabetes. So LDL cholesterol, cardiovascular risk, and non-statin therapy will be presented by Dr. Abdul Halim Kunsara, who's a consultant cardiologist, director of cardiology fellowship, He's the president of the Saudi Society of Echocardiography, King Faisal Cardiac Center. Dr. Abdul Halim, are you ready? You can start.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank the organizing committee actually for this nice invitation. I'd like to thank the chairman and the co-chairman for the introduction. And I think I'd like to start my presentation by a small question. If that goes on. So my first question, does anybody have doubt about the risk of high cholesterol? Because now we're really getting a lot of WhatsApp messages and they're saying, well, cholesterol is not bad, and they give different explanations. They're using the phrases from Quran by wrong way. So does anybody have any doubt? I'd like to see your feedback at the end of my presentation. I think you can share it. And the second question, does anybody have doubt in the importance of lowering it? Can we just live with whatever cholesterol that is we have in our body and take our chance? Because this is really important, because if you go to the guideline, you see clearly it is class 1 evidence, measuring your total cholesterol, looking to your HDL, looking to analysis of triglyceride, and all that are class 1. Not only that, even the non-HDL in certain groups is class 1. The data has been extended, and it's not only the European Society of Cardiology, it's European Atherosclerosis Society in conjunction as well. And not only they stop at this stage, but they're going to go further in certain groups and measure the ApoB. So I think really your doubt should be really zero. Now, as a matter of fact, lipoprotein A measurement was classified as class 2A. So I think really that doubt should really come out of your mind, because really this is affect badly our patient approach. Now, we do not want to rush to medication, because the guideline clearly showing that is your first step should be lifestyle modification. But sometimes we have to go to medication. The standard is the statin, but my talk is a little bit different because I'm sure that was covered by different lectures. I'm going to target the non-statin. So the question, when we need the non-statin? The first scenario to me, if we have a statin intolerance, you use the maximum required dose to achieve the target goal as per the guideline, and you didn't reach the target, so you need to consider non-statin. Number two, okay, if you at that target dose, you start to have a side effect, or the patient complain from your medication, or if you're dealing with very high risk group. Now the standard we used to buy in the past to call it high standard. Now the cardiology guideline has added a new term, which we call it very high. And this is really a big group, and very high group, or very high risk are group like people who have recurrent acute coronary syndrome within the past 12 months. If they have history of other myocardial infarction in addition to other vascular event. If, for example, they have ischemic stroke, if they have evidence of peripheral vascular disease, if you find evidence of progressive atherosclerosis in cardiac imaging, like a CT, if you did the life score assessment and they find their life risk is more than 10%, if there is a group of FH, familial hypercholesteremia, people with severe coronary kidney disease, people with diabetes, or have either long-standing diabetes, or they have more than 3 major risk factors. In these people, you really have to be very aggressive. But still, the guideline always say all individuals, no exception, the emphasis should be first in healthy lifestyle across the life course. Now, when we go to these different classes, which is non-statin, we see the statin are achieving 50% in moderate and high intensity. When we add ezetimibe, then we have an extra benefit of 25. When we move to the new class, PCSK9 inhibitor, we are reaching 60%. Our old friend, the bile acid resin, achieve only 15 to 25%. While we have the new groups of messenger RNA, and this has been group focused mainly in the FH, but they are really amazing in the figures, that is in the reduction in the LDL, especially in the familial hypercholesterolemia group, and always there to use in the top of the standard medication. And what we notice here, we have different groups of different medication, but all of them share the same advantage: lowering LDL, lowering non-HDL, lowering ApoB. They might vary a little bit in their effect in triglyceride. They might have a little bit difference in the level of the HDL. But what is the most important in all this is what is the cardiovascular benefit, or what is the cardiovascular effect, which is we are targeting. So the LDL or the LDL component or the cholesterol component is one target. But the most important, we'd like to see a clinical outcome. And for this, we'll start with the ezetimibe. Now, the ezetimibe, it works in the decreasing intestinal cholesterol absorption. This subsequently will decrease the hepatic cholesterol, increase hepatic LDL receptor, and subsequently will lead to reduction in the LDL. We have two big studies which address the effect of the cardiovascular benefit. The first was simvastatin and ezetimibe in cases of aortic stenosis, and the second was the study of heart and renal protection SHARP trial. Both showed reduction in the cardiovascular event against the placebo. It was modest. It was affecting non-fatal MI and non-fatal stroke, but the effect is there. However, recently we have also the IMPROVE-IT, and IMPROVE-IT done in 18,000 patients, and they followed over 7 years. So it's quite enough for us to see the effect. And what we notice in the IMPROVE-IT, there was 170 fewer events in comparing to the placebo, and you see the p-value. There was a significant reduction in the LDL. The ischemic stroke was also reduced, and the absolute value was small, but it was there and it was significant. The effect of ezetimibe has been shown by a different angle when we look to the genetic studies mutation in the MPC1L1, which is a naturally occurring mutation that inactivates the protein and was found to be associated with reduction in plasma LDL and reduce cardiovascular risk. We move to the second group, which is, I'm sure you have a lecture about it, which is the PCSK9 inhibitor. We have two major trials that is address the cardiovascular morbidity and mortality. The famous Fourier trial with evolocumab, or the Odyssey with the lerocumab. Both of them has showed decrease in the cardiovascular event, and this was related or proportional to the amount of the reduction in the LDL. We have to move to a new group now, and this new group were really, the main investment was in the FH group, because those groups are very expensive. They have a different, their main advantage really in the familial hypercholesterolemia, and also some of them, they are given by injection every 3 or every 6 months. And I think this will be a major breakthrough medicine, because the most facing challenge that is we have in our daily practice is the compliance with the medication. The compliance in one side, and in the other side, the media that is are passing a wrong message to our patient. For example, when you go to Ezetimibe, it's an ATP inhibitor. It's designed for a once daily oral treatment of FH, and it used to be as adjunct therapy to the statin. And really, there is a significant reduction of LDL by 26 weeks. And also has been shown to decrease one of the current standard therapy now for the FH, which is apheresis. So, but we did not yet have the cardiovascular effect or the reduction in the AFib demonstrated yet. The second drug, which is mibomersen, again is antisense oligonucleotide that is able to bind messenger RNA of the ApoB100 and subsequently trigger the degradation of messenger RNA molecules. This binding to the ApoB protein lead to production of the reduce the production of atherogenic lipid and lipoprotein particles. The inclisiran is now coming in the market, and really one of the companies are investing in it, which is again has significant reduction in the LDL, and as I told you, it will be given to be every 6 months. The new classes as well, which is Nexletol and Nexlizet, which is another interesting approach that is targeting FH. And how it works? By inhibition of the adenosine triphosphate citrate lyase, and it's decreased LDL 13 to 43% in the top of the current standard therapy, How it works? It works in this pathway, in the conversion of citrate to acetyl-CoA. We have SLY, and it is inhibited by bempedoic acid, and subsequently lead to reduction in the cholesterol synthesis. You see the statin is work in a different mechanism at a different enzyme level. And here another demonstration of this pathway when you compare it with ezetimibe, so it decreases cholesterol synthesis and lead to subsequent reduction in the plasma LDL. Now we move to our old friend, which we use for a long time, bile acid sequestrant. Their major issue problem was really the side effect of them. They work mostly in triglyceride, but they do have a reduction in the LDL as well. However, the cardiovascular event was not that pronounced. We have the fibrate that is also work in the receptor. And also we have the new medication. And of course, fibrate has been tested in 6 trials at least. And all these trials has been shown a modest effect in the reduction of cardiovascular effect. But while I was preparing this lecture 2 days ago, this has been published, which is the reduced trial. I'm sure many of you did not have a chance, but what is the beauty of the reduced? Now we're starting to look about triglyceride. We always have the issue with focusing on the LDL, but now this study has been showing that this triglyceride is really becoming clearly an independent, and I think this will demonstrate the effect of a new modality of non-statin medication. Now, I hope we don't have much of this clinic in your hospital. Nicotinic acid is again one of our old friends, has been always famous by increasing the HDL, but has been always famous by its side effect, even the slow release format. So the cardiovascular effect was neutral. We did not have a significant cardiovascular event reduction. And of course, as I told you, this applies even to the extended release format or the niacin plus laropiprant. So it's very important when we do this medication is really to do the frequent testing of our target. Now we know what to do in the lipid lowering. We do not know for this medication when to test them, but at least I think we can follow what we do with the statin. And so when with the initiation therapy, you should have really a close follow-up to see the effect of your medication. We do not want to just to start a medication. We want with the start of the medication, we'd like to see the target, that is we are reaching to our target level, which is the most important thing. Because in all these trials and all these studies, in order to get the cardiovascular benefit, you have to reach to the dose that is which has been studied in the trial. And this is, again, a pitfall in management of this patient, particularly the high-risk people. So please, this is very important to address, especially in the very high-risk group or people with acute coronary syndrome. Now, in the recommendation of the guideline to see the evidence, we look to here to the statin, and the statin is class 2A. When we look to the other classes, which has the cardiovascular benefit, the PCSK9 is class 2B, and we have the combination with bile acid sequestrant is class 2B. So it's really very important to go about this step ladder. So we need to know and to do. We have something nice to know and to do, and we have something not necessary to know, but we can do it later. But it's always have to remember this, especially in the high risk, we need to know and we need to do. We have spent a good time on mentioning different modalities, different medication, but I'd like really to stress again, although I'm a cardiologist, on the role of the prevention. And you say this prophet saying, عن المقدام بن معدي كرب قال رسول الله صلى الله عليه وسلم ما ملأ ابن آدم وعاء شرا من بطنه حسب ابن آدم لقيمات يقمن صلبه فإن كان لا محالة فثلث لطعامه وثلث لشرابه وثلث لنفسه. I think this is very important, and it's very important to address it in our daily practice. And believe me, our patient will really like this approach because it links them and it gives them the stimulus to follow what we say. So it's not only important what we know, but the patient is what the perception of his disease and how bad is this cholesterol or other element of the cholesterol. So always remember, prevention is better than cure, and we always, our success will be much higher in prevention. Always our cost-effective approach will be in the prevention. I think this is a nice review that is I encourage everybody to go with, because it went through a different guidelines and give you a summary of this task force. And I find it really very useful and cover a lot of things. And it's really recent, published in March 2020. My conclusion in a systemic review of evidence for adding non-statin lipid modifying therapy to statin, we found that is a benefit of Ezetimibe and PCSK9 inhibitor. We did not find for niacin or cholesterol stress transferase protein inhibitor. The new therapeutic options are growing up. They have a very significant LDL reduction, but you would like to see that transmitted in the cardiovascular reduction. Thank you very much.
Thank you, Dr. Abdul Halim, and thank you for being on time. Now let's move to technology, and we know that technology is important in the management of diabetes. Dr. Saud Al-Sifri, who's, I think most of you know, is a consultant and director of the endocrinology and diabetes department in Al-Hada Hospital. He's also the director of the specialist center in Prince Mansour Hospital in Al-Taif. Honorary Professor of Medicine, Medical School, University of Taif. He will talk about the digital health in the monitoring of patients with diabetes. So go ahead.
Assalamu alaikum wa rahmatullah. Thank you very much, Mr. Chairman. Thank you, Dr. Fahad. And thank you for colleagues. And I would like to really welcome everybody here. And I think we've been moving in these sessions in different, I would say, in different scopes. We have talked about it is, and then we moved into cholesterol, and again, how important to look at that. Now I'm going to move the gear into technology, and it's always the interest of physicians as well as patients in order to control their patients. So now, if you would see that most of those patients whom we look for, those with diabetes, always we wanted to have a very clear readings. How do they do at home, and how do we monitor them? So in this we are going to show that how we could utilize those technologies. And here I'm going to talk about the advanced sensor-based technology. And in this one, we are trying to make our best in order to see this. So here we're talking about glucose monitoring devices, and in this we're talking about a bit advanced sensor-based glucose monitoring. So in these ones, we are talking about disposable sensors, where it has got an extended wear time of almost 14 days. So we're talking about 2 weeks without any finger calibrations required from people who are wearing it. And again, it has got an automatic measurement, capture, as well as storing of glucose data from the sensor. And again, it has got a very quick scan of those readers over the sensor, which is collects and displayed the glucose data for either patients, caregivers, or healthcare professionals. Now let's have a look. How do we see them? Now here, when we talk about flash glucose monitoring, the ecosystem, and this is a fully digital health tools that works together. And here, if you talk about the mobile phone application, in which it can be downloaded from app stores, and this can be used either alone, or you can use it in combination with the reader. So you can use it instead of the readers, or you can use it in the combination of the reader. So this one is going to link the healthcare professional, caregivers, with this sensors. And in this one, you could see it either professionally at hospitals or practice-based by LibriView, or you can see it for those caregivers and others through LibriLink. So in this, it is cloud-based software. So this one can be used where it can store the data. And again, it can forward this to see it as a real time for those healthcare professionals whom they are following their patients. So this is how it looks in the blue. And the other thing, for those who have got what we call it, the LibriLink application downloaded in their iPhones, they can use remotely monitoring their people, either the father or mother. They can watch their beloved one who's wearing that sensor, or even as a healthcare professional, if patients permits you, you can watch that one and follow this. Now, how does it work? This is the ecosystem, so it's all in one. And in this one, it is web-based data management, which is a platform where it connects to your patient's data. So in this one, the only thing it needs, you need to sign up. So it's very easy. You don't need to have special hardware for that. And it is free and accessible online. Once that has been downloaded and signed up, then you can do a simple upload with this. So all those in the professional LibreView accounts, it can connect the patient's device to your computer if you are in a hospital or in a clinic, or you can invite your patient to upload remotely his data and share it with him. So either it could be done by downloading it while he's at your office, or you can send him an invitation where it can be uploaded. Now, how to view that report? It tells you all the patterns and the trends in that glucose, and it can help the physicians or the healthcare team to make an informed decision about your patient's health. So in that way, you could see your either at a real time or you can do it in that. So for patients application, they can use the mobile application to easily share their glucose data with you remotely from their device. Now, you can here connect to their practice. So with this, the Freestyle Libre link, it has a feature that it would ask patients easily to share their glucose data by their practice through the LibreView. So in that situations, it has got a secure online tool where your patient glucose data is automatically uploaded to LibreView. And then that is, as we mentioned, it is a cloud-based system which will enable you to access those reports once you want to see your patients as a virtual office visit. So it is very easily connect. So patients can do that connection, or you can send him an invitation through the email where he can accept that invitation and get to your practice. It's very convenient for us as physicians. So once you're connected, then your patient glucose data will be automatically uploaded, and this Freestyle Libre link is application to LibreView. So in that, you don't need any office staff to download the data. So it is automatically downloaded. So you can see and access those reports remotely through virtual. And with this, you could make more productive conversation and start, I would say, informed decisions based on these data. Now, how do we do this? It has got at least 2 steps, and in that you can identify your practice. So here you could choose whatever practice you are doing. So if you are, for example, doing more than one practice, for example, in a hospital or a private clinic, then you could choose it, and according to that, you would ask patient to do it. So once you have chosen your practice, you would invite your patients to go into that. So the patient is going to accept that invitation and would log into your practice. So here, this is the way. And then you would search for example, if you've got more than one patient, for example, 10 or 20 or 30, you can search that patient based on your practice. And from that, you can collect that patient's data. So this is how it looks. So once you have put this, then the link of that patient would be based on your selection of the practice. And then you would go into that LibreView account where it is identified by email address to your patients. And then you're going to save that. And once you wanted to have it, you will have all of these data and you are going to see it. Now we would move into how we are going to see these data. So now if you would see those new ambulatory glucose profile reports, you would see that there was a recommendation and consensus from the international consensus on time and range. Now, we remember that in different devices and different this, you have got different tools or metrics where you are going to look. Till recently, we have been looking and still for the HbA1c, which is one of those, I would say, agreeable glycemic metric where it can be used. Now, once we are talking about those continuous glucose monitoring data, we would need to have a unified and consensus on what kind of metrics that we are going to use. So here, the international consensus, they have agreed on time and range, in which they have recommended that it is mostly aligning to a common metric on glycemic status. And with this, we are going to go quickly on what do we mean by time and range, and then the standardizations for the ambulatory glucose profile, along with their daily glucose profile, how does it look? And then we used to have in the AGB reports what we call it estimated A1C or estimated hemoglobin A1C. And now we are going to use the term, which is glucose management indicator, as a replacement for that. And then we will try to have some of those important things. Now, just to remember that time and range, why do we need it once we talk about CGM data? Because all of you are aware that once we talk about HbA1c, it has got its limitations, in which it reflects the average glucose over the last 2 to 3 months, which does not reflect what we call it the real-time excursions, either of hypo or hyperglycemia. Now, time and range, it means how many minutes your patient has spent within the target, within that norm. So if you talk here, it would tell you, if you would see the green area, this is time and range, and it tells you from here that you can assess by just looking at that how many of those percentage of the readings and the time of each day that your patient was within the target or above the target or below the target. And the more he's within the time and range, within the controlled readings, that gives you a better reflection of his control. Now, it has been consensus that almost every 10% increase in the time and range, it's almost equivalent to 0.8% decrease in the hemoglobin A1C. i.e., if your patient has spent 70% of his time is within the range, this will give you an average almost of 7% hemoglobin A1C. If he would spend more time in range by 10%, it means he's going to have a better control by reducing the hemoglobin A1C by 0.8 to 6.2% in that. Now, why do we have this? Because we knew hemoglobin A1C has been always linked to the chronic complications, and here time and range, it has been linked and associated with a greater risk of reducing the microvascular complications. So if you would see every 10% decrease time and range, this the risk of retinopathy and microalbuminuria will increase. i.e., if patient is having, let's say, 50% of his time within the range, that would give him a certain percentage. But if he would be less than that, then that would increase it. Now, this has validations from different outcome measures from diabetic clinic trials. And here they looked into different categories, and they came up with this consensus that almost 10% decrease in the time and range, that would be reflected by almost more than 60% increase in the retinopathy, or 40% increase in the microalbuminuria, and as a reflection of nephropathy. So it's always an important to keep this with it. So the more time your patient is spending in the time and range, this will result in decrease in hemoglobin A1C. So if your patients that as we would going to agree on, if 70% of his time has been spent within the time in range, which is between 70 and 180 milligram per deciliter, and again, this is depends on what kind of population you're looking at. So in that situation, 70% of time, if he's spent it in time and range in the green, that is almost equivalent to 6.7% roughly. So this has been chosen because this is mostly correlates with hemoglobin A1C of 7%, in which we have identified in the DCC trial and UKBDS. Now, if your patient is able to maintain his glycemic readings within time and range by 80%, that would even further reduce the hemoglobin A1C by more 8%, and that would reach almost 5.9%. So it tells you the less time in range, the more hemoglobin A1C. And the more time in range it has been spent in that, whether he's type 1 or type 2, he's going to have a better control in that. These are the clinical targets for the CGM data interpretations, and this is the recommendation in which we have alluded earlier. And from here, we wanted to let you know that we are here, those time and range targets are based on the populations whom that we are studying. So for example, if you're looking at those young adults with type 1 and type 2 diabetes, then again, we are looking for more than 70%. Okay. Okay. Thank you again. So now here we wanted to have those recommendations, and we wanted to see what would be the clinical targets. Now, if you would see in the green, and again on the far left, we're talking about kind of population type 1 and type 2, whom they are younger than 25 years of age, whom they are non-pregnant. And with this, our target of time and range, they should have at least more than 70%, which is equivalent to almost 7% of hemoglobin A1C. Now, the second column, here we are talking about those who are elderly, more than 65 years of age, whom they are type 1 or type 2, whom they have got multiple risks. And again, here, if you would consider at least time and range should be more than 50%, but the time below range, in which i.e. hypoglycemia, less than 70 milligram per deciliter, should be less than 1%. Now, in pregnant type 1 or type 2, again, in those, especially if we talk about pregnant type 1, should be more than 70%, while gestational diabetes, pregnant, they should have at least more than 80%. Now, this is how we need to see the AGB report in the lib review. So it is, I would say, very simple if you would see on them. And now I'm just going to tell you what does it contain. So once you would see it in lib review, this is how it looks. So the first part, which is this one, it talks about the statistic of glucose and targets. And again, with this, we are talking about time and range, time above range, or time below range. And again, here, the second thing, we talk about time and range. So in this, we wanted to have it as green as possible. And then the third, which is the ambulatory glucose profile, AGB. And this is how it would tell you how fluctuations does it have. And then the fourth one, which is the fourth part, it talks about the daily glucose profile of every day. So in this, I would go over it very quick just to give you that it is very simple if you would consider those. So here we are looking at the time profile. And again, if you would look at time and range, here more than 70% for this population. Here in the initial, it talks about 88% of the time that this CGM or freestyle was active. here, again, it would tell you that what we call it glucose management indicator, or the previously called estimated A1C 6.5%. Again, the variability here, it is 31, and always we have to look for a target of less than 36%. So these are the recommended for those adults, young, who are non-pregnant. Now, this is just to show you the green. The more green you would have, the more time and range, and this is reflected with the better hemoglobin A1C control. Now, let's just have a look at the other one. So the more effective time and range, you would have it better. So this is how it would look in the LibreView once you open it. It's simple, so it's color coding. You can appreciate that here. For example, in this patient, that 75% of his time, which is identified between 70 and 180, has been within the time and range, while only 6% or 16%, which is 22%, it was above the target, and 3% was below the target. Now, this is how it looked in LibreView. So we would have a clearer of what we call it here, the AGB. So in this AGB, if you would see, we're talking about the 50 percentile, where it would tell you the mean of this. So if you would see in this patient, most of his mean 50 percentile has been there, while once you talk about 75 or 95 percentile, it has been in a single day either up or below that range. So it can tell you what was the time where your patient was out of fit. So here, maybe at the midday, so at 12 noon, you would appreciate that your patient, his fluctuation was higher, and at this time, mostly he has got a better or a more reflections in that one. Now, just to show you how it would look, so now we would look into the third part of it.
1 minute,
again,
so 1 minute.
I'm just finalizing. So here it would tell you the week, how does it look? So this is for what was the time in which it was recorded, and for this it would tell you here is the date, and again, according to time, it would tell you what was your patient. So now here you could appreciate that in this patient has got almost, there is the midnight or early Friday, most of the time he's below the range, so it has to be corrected. While here on Sunday in the afternoon, mostly it has been above the range. So always this has to be considered. So now this is how it looks. So it's very simple, and it is standardized AGP reports, where it makes very easy once you look at the LibreView, and you can see your patients from there, and it can engage you, I would say, in a very, very fruitful dialogue with your patients. Now, with the final slide, always we have to make sure that with the new AGP report, the time range is always allowing us to quickly assess the patient's time, which is spent either within the target, or above that target, hyperglycemia, or hypoglycemia, which is below the target. And then again, AGB graph, it helps us when that patient has been out of the range, at which time of the day. And then again, it would tell us the trends and the patterns of that glucose fluctuations, whether it has got a certain trend, a certain pattern or no. And based on that, we could make an informed decision, and that would help us in doing this. So, Mr. Chairman and dear colleagues, just to finalize with this comment, now having, I would say, the continuous glucose monitoring, the CGM data is always very important, but sometimes having a lot of data will make it even very difficult for physicians or healthcare professionals to take a decision. So making it very simple and I would say new report, that would make it even more fruitful. Thank you very much for your listening.
Thank you, Saud. Very nice. Well, just for the sake of time, I have a question from the audience. And I will just throw one probably question for each, depends on the time. Dr. Mohammed Dawish, one of our audience said, if patient TSH is suppressed and nodule and has a nodule, do we need to do ultrasound thyroid or thyroid uptake scan?
Can I hear the question again, Dr. Fahad?
If a patient has suppressed TSH and has a nodule, okay, so do we need to go for thyroid uptake scan?
Yes, the uptake scan is mandatory in this case, and this is mostly his hyperthyroid. The idea behind it that maybe we'll find a clear toxic nodule, i.e., there is no need for fine needle aspiration.
Dr. Abdul Halim, if patient with ischemic stroke and normal LDL, do we need to put them on statins? If yes, for how long?
Yes, we have to put them on statin because they are considered one of the high-risk group. Now, majority of them actually they require lifelong, but of course depending on the patient compliance. The problem with the stroke, the two things that is we were looking for is one of them the exercise and the diet. The diet he can comply, but the exercise unlikely a patient with a stroke will be able to do it. So majority of these people end up to be lifelong medication.
So is there any interference between the sensor and the surgical operation? If the patient has to go for surgery, do we need to remove the sensor? Saud?
Thank you very much.
Yeah.
I'm not aware of anything that it would interfere between the sensor and the surgery, but always we have to remember that with the freestyle sensors, it's always very critical once we talk about very low severe glycemia or hyperglycemia. At that time, it might not be very accurate. But I'm not aware of anything that it can interfere during surgery with the sensor.
Dr. Dawish, female with low-grade differential thyroid cancer, do we need to do total thyroidectomy for her?
This is based on what the papillary thyroid cancer? I mean, they
low-grade, yeah, looks like.
Yeah, I mean, again, there is an evidence, even BTC up to 1.5 centimeter, no other feature like extrathyroidal or no lymph node. There is study now up to 10 years. You can leave this patient just what you call it stratification. Every maybe 1 year, 2 years, just to repeat ultrasound, even without removing. The study have been finalized that only less than % what you call this active surveillance, only less than 3% required to go for surgery. 93 or 95% they don't require, even it is a proven papillary thyroid carcinoma.
Thank you. Dr. Abdul Halim, how do you define statin intolerance?
Statin intolerance is a very important concept. Number one is development of the side effect within the first 2 weeks of starting the medication. Number two, that is when we stop the medication, the symptom disappear. And number three, which is again important, when you re-challenge the patient with a lower dose or a similar class, that is, you will have the symptoms.
Thank you. So where to get LibreView and View and the Libre link?
It can be downloaded now for the Libre link. It can be downloaded from App Store, so it's there. You can download it and just scan it so that it will identify the sensor. You can use it along with the sensor or with the reader, and even LibreView. You can have it from there. It's an online. It doesn't need upload. So the only thing you would have it in your computer so that you can access it.
Okay, thank you. Just like thank all the speakers for their nice and informative lectures, and the audience for listening. And we close for the first part of this night, and we will reconvene at 9 o'clock. Thank you all.